Hello, everyone, and welcome back. I do apologize for being away for so long here. Had a bunch of trips and other things, but I thought we'd come back with a classic misdiagnosis case. So, this is the x ray that was sent to me by the general dentist. And see, this is the pre op image here. And they also sent over this not so helpful cone beam. Stop taking full field cone beams. Here's the bite wing. But what had happened is they had already accessed the tooth, couldn't find the canals, and then sent them back to me. So, when I talked to the patient, what he told me was that they were reviewing his full scan and they noticed that he had some lesions on the x-ray and they were worried about it being an infection because he had just recovered from prostate cancer and chemotherapy. So they accessed the tooth, and as you'll see once I dry everything out here, they had a little bit of difficulty getting inside here. The patient couldn't open very far. He had a little bit of anxiety too, but he drove from a very, very far way away, so I was trying to do my best to get it done. As you can see, the access was a little bit too much towards the lingual. So that was me having the patient move his head to try to get a little better access to it. I know it's a little bit difficult to see with it not all the way zoomed in, but they had found the mesial lingual and the distal canal, but they had not gone all the way to the mesial buccal. So what I'm going to do here in just a second is take that workhorse burr and go along and clean out, find the canal, and then we'll have a surprise to all of us, to everybody's surprise here. As you can see, the workhorse burr they didn't unroof everything. It's because of how the tooth was angled and how he was angling. I understand how the axis was off. Definitely a larger axis than I would have preferred to have done, but it's okay. He's here now. We're going to get him all taken care of. Now, when I get inside here in a second, what you'll notice is something quite surprising as far as the tooth. I do all these live and I don't, time it out properly as I should have. But anyway, the fun fact is the tooth is still vital. You'll see him jump here in just a second. And unfortunately, that means something went wrong here. So I ended up doing some intrapulpals. It took a while to get the tooth all the way numb. But here's the thing. How can you have a vital tooth and have lesions? Think about that for a second. In order for there to be a radiographic radiolucency from bacteria, they would have to eat all the way down to the very bottom. And you might say, well, Scott, it could be that it's just one root that was in there and the other was causing the infection. And I'm going to show you here in a second, that's not the case because all three of these canals were still very inflamed. When I scrolled in on this useless panel that they sent over, I couldn't see anything. So let's go through my imaging and show you what I was able to see as we scroll through. So going down the tooth, you can see not much going on here, maybe a little bit right there with my mouse that you can see something funky, definitely something weird going on there. And as we get down to the bottom, maybe a little something there, okay? So we can definitely see there are some black spots on the x-ray, but when we look at them in the other angles, those aren't infections from a root canal. And this was the point of this video, is it's very important to realize that the skills that each and every one of you have in diagnosing things using two-dimensional imaging, which you have done for years and years and years, even if you're just starting dental school, you've looked at thousands of PAs. Those skills do not translate to three-dimensional imaging, and what oftentimes happens is you're going to over-diagnose. And that's exactly what happened here, and this is why it's very important that when you buy a cone beam, you take some lessons, you take some classes, you talk to people about how to interpret it, or more importantly, send it off to a radiologist who will tell you to, correlate everything with clinical findings. But most importantly, make sure you know what you're looking at, make sure you know what is normal. If this had been my patient, I would have cold tested the tooth, which would have been, and I know I have a request to go into cold testing. I will definitely put that into a lecture for the residents here soon. So I did hear you and I will do that, I promise. But if you had cold tested the tooth, by the way, this tooth was asymptomatic. This tooth was treated with a root canal because of the quote unquote lesion inside there. And it just makes me sad because this is a patient who didn't need to have a root canal done in the first place. And this was because of misdiagnosis. The other thing that everyone should know is chemotherapy drugs, specifically cisplatin, which is used in prostate cancer, often causes osteoporosis. That's what we were seeing in the imaging. That is a classic sign of osteoporosis. I see it all the time in my postmenopausal patients. This is something that if the doctor had more experience with reading cone beams, they would have known this is a variation of normal, especially given the patient's medical history. So for those of you who didn't watch my video recently explaining some of my history, this was exactly what my thesis is on. If you're wondering where to get more information, I would start by recommending Dr. Kadami's book on interpretation of cone beam, and it's a fantastic tome. Full disclosure, he was my thesis advisor. He's a good friend of mine as well, so do take that into consideration. But it is a very, very good book that goes into a lot of the errors that we are just prone to having as humans. That's one thing we don't like to really talk about, I think, in dentistry is we are humans. We are prone to causing errors. We make mistakes. All of us make mistakes. I make mistakes. The people who taught me make mistakes, and you will as well. It's just important to realize what type of mistakes you are most prone to making and try to avoid them as much as possible. The medical field is far, far, far ahead of us compared to dentistry. It's almost embarrassing how bad dentistry is with radiology and its interpretation. Now, you can see this poor patient, all 3 canals are still very much vital. He had complete lip numbness. He had complete tongue numbness. Didn't cold test because it had already started. And once you get the coronal pulp out, they're not going to feel the cold anyway. But he was jumping the whole time. Turns out he's also anxious about dentistry. So that was a fun 1-2 punch. He does travel from almost 4 hours away. So we kind of had to just hold on as best as possible, do some intrapulpals and get him numb, because I don't think there was any amount of anesthetic I could give that would get him completely numb. The good news is once you get that pulp out, it's pretty straightforward to get the rest of the tooth taken care of. We're going to use the gentle wave here just because we were in there. We had it open. It's a great seal. It's a good case for the gentle wave just to, show off and get it looking as clean as possible. I also was a little concerned about that gold crown. You can see the black staining underneath there. One of the cool things about the gentle wave is that if there's leakage under the crown, you're not going to be able to get a good seal, and the crown's going to dislodge during running. That's the patient's finger. Don't worry. Like you can see, I have gloves on. But the gentle wave is going to dislodge, or it won't get good suction, and the crown usually will pop off during the treatment itself. So that is a normal thing to see here. By the way, there have been no cuts made to this video as normal. All the cuts that you see are just so that it will stabilize, because the footage is very shaky. You can kind of tell by his tongue. He's moving quite a lot here. Once again, had some anxiety, but he had driven from so far. He didn't want to come back on meds. I did offer it, and he kind of just powered on, and very good on him on that. So with the sound seal, I'm finding that it's best to just completely cover the tooth. I know with the clean flow, sometimes you can get away with just doing the coronal aspect of the crown, but I found that it tends to leak. It's not as stable either, and it's more predictable to completely cover the tooth, both buccal and lingually, just to kind of get it all sealed up. Right now, what I'm doing is just putting the sound seal on the what do we call it? Is a former matrix? I think it's a matrix. Go back to my old video. I forgot about this. I'm really good at knowing what these things are called. The former matrix thingy. I was filling it up there. Getting that in place. And you'll notice it's a little hard to hold in place. That's because the initial axis was so large. For the smaller axes that I tend to do, it's very nice because it holds the former in place. It has that little triangle that goes down to help form the shape of it, and that stabilizes it. The problem here is the hole is so large from the existing access that it moved a little bit more than I'd like. So you see, I had to do a few things there to get it to fit. Highly recommend using that Glick instruments as well to get a good seal around the outside of this. And then 20 seconds of light here just to get everything good to go. And, do I need the gentle wave in this case? No, we could have done it traditionally. I tend to, at this point, only use the gentle wave on really infected cases where I would be concerned about it, still leaking. If I'm really concerned about bacteria, I'm going to do that in those cases. In this one, though, the case was still vital. This case isn't going to have any problems because it didn't need a root canal in the first place. And that's, so did I have to use it? No. However, I had already talked to him about it. We were already set up for it. It's not going to hurt anything. If anything, it's going to get it more clean. So may as well. So we're going to go ahead and run the gentle wave here. I've sped it up a ton, so you don't have to sit through that whole thing. And I think I mentioned this in the previous video. I have found that it is good. This is a technique from the old 3-piece molar style gentle wave to go back and re-access, I've found that I'm starting to do it on all my cases. It does seem to make a big difference with the seal and getting everything working better. Just go back in and re-access, get any of those undercuts out of the way, and it tends to work a little bit better with the machine itself. So we're going to go ahead and run the cycle here. Like I said, I sped this up quite a bit. And you'll see me swap hands back and forth. One of the things I've realized you can do is using a bunch of keyboard shortcuts. When I switch it to the left hand, what I will be doing is usually doing my notes or something else, working on, I crop the pictures at that point, make sure everything's done. It just saves a little bit of time because we're going to be sitting there for 8 minutes anywhere. Like I said, this has been sped up quite a lot because you don't need to see it just sitting there for 8 minutes. That would be a very terrible video. And all of you would probably click off. So I was able to run the cycle with no issues. We had no problems with it losing suction, anything like that. So good news there. And the cycle went really well. So almost done here. We're going to pop this off. As I'm recording, you should be seeing something a little bit better, but my computer is definitely struggling trying to render all that. So, okay, here we go. I think we're caught back up. Oh boy. If I'm way off on the video, I do apologize right now. It just jumped ahead a little bit. So anyway, you pop the matrix off, suction it out, and then, okay, here we go. Now I'm back to real time, I can tell. So I do need to get that video up, that card upgraded, but video card markets are still insane. So anyway, sorry. Drying everything out. We'll do the squirt technique for this one, but I did want to talk, this is a cool video for two reasons. Number one, the misdiagnosis and me getting to rant a little bit about the importance of knowing what you're looking at with cone beams. And number two, talking about the squirt technique and what to do if you can't get all the way patent after running the gentle wave, after running the files. Now, my working length here, I believe, was 21. And what I generally do is I'll take the 2006 down, let's say if it's 21, I'll probably go down about 16, 17 millimeters, give or take, just so that I give enough space that the cannula of my beta can fill it inside there. You'll see it's even tough for me to get the picture. That's how little space there was. So I do understand why the access was difficult for the general dentist, but my major complaint is that it should have never been done in the first place. Yeah. Anyway, what's going to happen here is when I go back down with my K files, I'm not able to get all the way to length on the mesials. We were a little bit short there. They didn't join, so I'm not sure why there was some difficulty there. Generally with the gentle wave, it's going to remove any impediments very nicely, but you'll see here in a second after I get the sealer in that we were definitely short initially. So there's a few different ways if you're trying the squirt technique and you cannot get down to length with it. At this point should be even with that hub. First thing is do some watch winding back and forth. Definitely the best video of me, watch winding with my giant hands. You can't see anything. And if that doesn't work, the next step is to try different files. So what I'll do here, I believe I go to a 15 next and just kind of go down to smaller file sizes, see what you can do. I do put a slight bend on the file, and that one you can see it's around maybe 18. I think I get it down to about 19-ish. By doing the watch winding, but still not all the way patent. You can't see. This is why I don't make hand filing videos, you guys. You can't see anything when it's on a tooth. I guess I could do it on an extracted tooth, but when you extract them, they have all weird things happen to them. I don't know. Maybe one of those clear blocks. I don't know. If anyone's still watching at this point, drop a comment below just so I know. But what I have found works really well is to actually take a rotary file back down. So the rotary file is removing some of the dentin, but it's also carrying the sealer down really nicely for me. And you can see I dropped both of those to 21, no problem there. And I'm not going to go back in and re-rinse or anything like that. I'm going to use the rotary file pretty much as my file to carry the sealer to the apex. So if you're trying the squirt technique and you've had some difficulties with, getting patent or getting to the proper length that you've measured, and you've tried a 10, a 15, a 20 K file, nothing's working, try a rotary file. Sometimes like a skinny one, do a 14 or a 17, depending on your comfort level, and see if that will help. I have to do this maybe once a month, maybe once every other month, but it's just one of those good skills to have in your back pocket. And then I'm just double checking here with an 8 to make sure we are truly patent all the way. And that felt great. For those of you who have been doing endo long enough, you know the feeling when you actually drop into patency. It's a very different feeling than when you're working everything up. It's like the pressure is almost relieved once you've dropped through the apex. And so that's what I was feeling for there, because once again, it's okay if this fill is a little bit short on a tooth like this because it didn't need a root canal in the first place because it's vital. So I'm okay doing a short fill if it's a millimeter or two. This one ended up being great all the way to the apex. But I want to make sure that we truly are patent because, as a reminder, if you're doing the squirt technique, if you are not patent, you're going to have issues with, I think one of the terms for that is vapor lock, where it comes in. If you don't have a clear line straight to the apex, you're going to be short. So it's very, very important if you're going to be doing the squirt technique that you are patent. It does not work. It doesn't work great in cases where you're ledged or cannot get to patency because there's nowhere for the space to go. And that's why in these cases, you'll see I almost always have a sealer puff, is because that pressure is going to hydraulically push the sealer and the gutta percha through the apex and get a little puff of sealer out if you do everything properly. So let me know if you guys want another update on the squirt technique. I've talked to a few of you offline at the AAE and in person, and we've talked about a few different things, but I haven't heard many comments recently about it. If you're trying it and you have any questions, please drop a comment below. I'm happy to make another video. I just don't know what what problems you're having. So I'm happy to help out where I can, but I don't know what issues you've had, and I don't want to make the same video over and over, saying the same thing over and over, even though that's sometimes what I feel like I do. But you all keep wanting more and more of it, so here I am. I'm a slave to all of your comments and likes and all that fun stuff. So on that same note, like and subscribe, because we'll keep making videos as long as you guys keep watching them. But the gist of it here was, as far as the reason I thought this was important, is it does show the importance of being patent to make sure that everything does look good. And obviously I think I've beaten that horse to death of make sure you know how to read cone beams. So here we are finishing everything up. I don't know if I've talked about this before. I keep a scrubby brush on the isopropyl alcohol for when I do gentle wave. And it's really nice when you finish the case because you already have the scrubby brush built in. So it's really cool to get in there and get all that junk out of there, get everything looking perfect. So what we're going to do is pack mac these, like always, with skinny canals, even though they were able to get down a little bit of the canals, they were still pretty small shapes, and PacMac just helps make sure everything is well sealed up. I'm happy to say he didn't have any issues with the pain during the obturation during this, so the only issues were really at the beginning, unfortunately. And that's something you do see sometimes with pulpotomies, is that it makes the pulp really inflamed if you don't put enough calcium hydroxide in there, and that's I think what happened here. So what I'm doing here is just finishing up. There was a little pulp stone. There was gutta percha hanging out between there. It just bothered me. I knew it was going to look funny on an x-ray. It's not going to make a difference, but I cleaned that out and made sure we got all the cavet IRM temporary off the side, because with metal filling materials, my favorite, and the only one that I'll use as long as the patient and doc are okay with it, is amalgam. Composite, it's very difficult to bond effectively to metal like this. It's, they're not really concerned about aesthetics if they got a gold crown, so it's going to be okay. But what we cut out there was the photo and the taking the x-ray. So looked great as far as the down pack, and now we're going to be filling it up. I ended up needing three spill amalgam compules to get this fully sealed. So that tells you just how large that access was, that it was that many, that large amount of amalgam to actually get it inside there. I'm working with my youngest assistant right here. So this is why there's a little bit more of a delay, which is, it's taking her time to get used to packing amalgam and knowing the instruments and things like that. She's doing great. But if anyone out there is a more seasoned dentist or a military dentist, and you have tips and tricks for teaching assistants on amalgam, I'd love to hear it. I would use more and more of it if I could, but the general dentists in my area really don't like it unless it's for this case right here. So I tend to only use amalgam on friends and family, and gold crowns like this. I think it's the best material for posterior buildups, especially if you're going to be doing a new crown on top of there. Who cares about the aesthetics, because you can block it out. Everybody's using zirconia anyway. But that's a long-winded way of saying I haven't trained many people on the best way to place amalgams and how to be a good assistant doing it. I've done a ton of amalgams, but haven't had the experience training. So if you have any tips on that, please let me know. I know I have a bunch of military friends out there who are probably cringing at my technique right now because all of you did just amalgams for, your entire time in the military. But if you have any good tips, let me know here. So we're just finishing up the case here. I did one thing I forgot to mention is I have found that the B&L, they have this blue plugger. It's, I believe, a 70 and 140, I think. I'll put this down in post under here what the actual numbers is, but it's the blue one. And the stainless steel stiff side is about the size or diameter of a traditional amalgam condenser. It's just much longer. And I've found, and have been using this now for probably 10 years, it is the best way to place amalgam really far down inside the canal itself. Actually, I think it's a 6120 because it's a 7140. Yeah, because my normal one is 3570. And that's the cool part, is the flexible end is the same size as my normal thick end, which is what I use to sear off the gutta percha. So it actually, if I need to go into the canals itself, it actually still fits, even though it's a much larger size. If that doesn't make sense, let me know. I can make a quick short video on it on what I was talking about there. But if you haven't used that before, if you're having trouble with amalgams on axes where it's really deep, let me know. Using the acorn here. This was one we weren't actually allowed to, at UOP, we weren't allowed to have an acorn, which I think is the meanest thing in the world. So it makes such a difference in your ability to make amalgams look decent. So dental students, if you are able to bring your own stuff into SimLab and you're having trouble with it, buy an acorn off of eBay, because it makes doing the margins and carving a billion times easier, especially with those traditional GV black shapes. Are we even teaching people GV black shapes anymore? I hope not. That's very outdated. Cool guy, did a lot for dentistry, but that's not the material we use anymore. So hopefully we're not. I haven't been to a dental school in a while. So let me know if you're a student, if you're still learning those techniques, and when you graduated, if so. But we certainly learned it, and the acorn's a great tool for that. So anyway, I think here, yep, we're just polishing this up, a little bit of cotton pellet to get it looking beautiful. I was pleased with my terrible amalgam. It's going to work because amalgam always works. That's the beautiful thing about it. We checked the bite. It was rock solid. But I always am hesitant putting amalgam restorative on the internet because there are people who are absolute artisans at it, and I am not one of them. So anyway, final picture here just to make sure everything looks beautiful, and you'll see that still photo in here in just a second. And then the image is coming up as well for the final radiograph. So thank you all so much for watching. Hopefully this was an interesting one for you. I always hate it when we have cases where it's misdiagnosed, where the patient didn't need the root canal, and I'm here to help as much as possible. If you have any questions about what I was talking about, if you'd like to see more on the interpretation, it's pretty dry, but it's a very important skill to learn. So thank you all so much for watching, and as always, I will talk to you all next time.